Thank you very much for inviting me here. It's a real honor to be able to speak to you about this illness and to share some of my experiences with you. I have been doing 2-day exercise testing with people ill with ME/CFS for about 10 years. And what we just passed out to you are the results of some of the exercise tests, which I'll get to later on. The slides are, it's a lot to put on a slide, although I did put it on a slide. But I realized it's a lot to put on a slide, so I wanted to give it to you so you could study it a little bit more closer up. Can you all hear me? Can you hear okay in the back? Okay, great. All right, so the problem with this illness is that it's a diagnosis based on symptoms, primarily, an exclusion of symptoms, and we really have no good definitive marker for this disease. And so to get a diagnosis of ME/CFS often can take years. Many trips to many specialists, lots of energy used up by patients who don't have that energy, and extremely frustrating. There are not a lot of physicians who know much about this illness, and it's particularly frustrating when you're a patient who doesn't have any energy capital to spend to go about finding somebody who does know about this illness. In terms of long-term disability, or LTD, I have it up here, at least in the States, and based on what I've listened to earlier today from the attorney that they had speaking, we have the same challenges, and that is to somehow objectively indicate that there is some kind of physiological or metabolic or endocrinological or rheumatological underpinning to this illness. And because we don't have a definitive marker for the illness, it makes it very difficult. So demonstrating and quantifying the degree of impairment with ME/CFS is very difficult because of that. So before I launch into how we use the 2-day exercise protocol to do item number 3 here, to demonstrate objectively that there is something awry physiologically, and then to begin to try to quantify it, I thought after we spoke following my talk this afternoon, it was suggested that I just revisit this whole notion of how we produce energy and to share that with you first to make sure that we're all sort of working with the same information. And because this illness is ultimately all about energy and lack thereof. So we basically have 3 ways that we produce energy. And one of those ways is through anaerobic energy production. And we have a system that provides energy which is readily available to you in your cells right now, ready to allow you to jump out of your seat and run down the hallway if you need to, in case of an emergency, for example. And so you see here our unemployed NFL quarterback Tim Tebow saving 2 puppies from fire, which is a commercial, I'm pretty sure. And this energy system is something that provides energy for you for up to about 15, 18 seconds. And then it kind of runs out. And you don't run out normally, you don't just stop. But you have other energy systems that kind of take over as this one is running out. It replaces or replenishes the energy fairly quickly, but it does require recovery. So fortunately, we have recovery, and we have this other longer-term anaerobic system that can launch into action to support the first energy system. And it's another way of producing energy. And it does pretty well at producing energy for anywhere from about 15 to 75 seconds. And if you don't slow down, eventually it will slow you down because it has byproducts of that energy production. One of them is lactic acid that will cause you to slow down. So, we do have a third energy system that powers most of what we do in our daily activities, and it's called the aerobic energy producing system. There are other names for it as well. But this energy system is what's powering you right now as you're seated here at rest. And then when you get up and do most of your activities of daily living where you have to be active on an ongoing basis, or maybe you want to go out and jog for a couple of miles or take a brisk walk somewhere or go through the mall or whatever, this is the energy system that does that for you. It's also the energy system that allows you to run a marathon if you train for that, and it's very responsive to training. And you can increase it pretty notably with graded exercise training. The problem with ME/CFS is that this is the energy system that does not work well. And at rest, for an ME/CFS patient, it provides energy, although if they're experiencing a symptom flare, they're experiencing post-exertional malaise, this won't even provide energy very well for them. And they really have to rely on those first two energy systems, which do provide energy, but there's a payback in that they have to recover. They have to replete or restore themselves, which means functionally for you, somebody with ME/CFS, they have to stop. They have to stop so those systems can recover. They're not ongoing systems that work endlessly like the aerobic energy system. But for ME/CFS, the aerobic energy system is not to be counted on. So they have to get their work done another way, using either this system at a very low level or the other systems, which you now know run out. They run out of gas, and they need recovery. On a daily basis, what that means is that some activities for ME/CFS patients can be done, but then it requires rest. And with sufficient rest, they can get up and do some more, but then they have to rest. So the implications are pretty dramatic for your daily life, because how you organize your daily life is highly impacted by this. This is data from Stacy Stevens' lab, and I apologize. I just swept this into this presentation quickly, and I wasn't able to get this stuff fixed here, but I'll explain it pretty quickly. You probably can't see that too well. These are 30 patients who did an exercise test that lasted 5 to 10 minutes, all with ME/CFS. 75% of these 30 patients took 3 days or longer to recover from this 5 to 10 minute exercise test. 3 days or longer. This is what we call post-exertional malaise. Here are some of the statements that these patients shared with about how they felt during that recovery. They felt out of sync, dull thinking, which speaks to the cognitive effects of this post-exertional malaise. I saw spots in front of my eyes. How many of you have seen spots in front of your eyes after exercising? That's not a normal exercise response. Would you agree? We don't want that to be a normal exercise response. This is quite dramatic. And you see over here, you've got 11 patients who took over a week to recover. I've had patients after completing the 2-day exercise protocol who took 3 to 4 weeks to recover. So post-exertional malaise is about what that picture shows you. It is a defining characteristic of ME/CFS. Technically, it's malaise. We don't like to say fatigue because that really doesn't fully describe it. That lasts longer than 24 hours. To be diagnosed with ME/CFS, one of the criteria is that you have experienced this for more than six months. It is really not just fatigue because there are other symptoms that accompany it. Lightheadedness, breathing problems, muscle pain, cognitive issues, headaches, nausea, a whole host of symptoms that I see, even though I know no French, but I gleaned enough from that poster right there that there are many systems involved in this autonomic nervous system, cardiovascular system, musculoskeletal system. It's all-encompassing. By far, I think most patients would tell you that the two most striking symptoms of ME/CFS include post-exertional malaise and cognitive dysfunction that accompanies post-exertional malaise. It's frustrating when you can't find those words or you can't you don't have the energy to actually focus and read something one time and understand it. You have to read it over and over and over again, but you don't have the energy to do that either. So Lucinda Bateman is a physician who treats fibromyalgia and ME/CFS patients. She's treated patients for quite some time. And her comment about post-exertional malaise is that treating post-exertional malaise once it happens is much more difficult than preventing it. And my talk this afternoon really focused on what we can do to prevent symptom flare and post-exertional malaise. And one of the first things that we need to focus on as a patient and as clinicians who work with patients is that they need to be preemptive in their rest and restorative behaviors. And what that means is that you don't wait until you feel like garbage to go out and try to, or to take a nap, to rest and recover and restore. You rest on a schedule. So for an ME/CFS patient, what this means is that they may have to schedule into their day periods where they just lie down, close their eyes, and lie down. How often they do that and for how long will vary from one patient to the next. But it's hugely important because it's that restoration of those anaerobic energy systems that are doing more work than they should have to in ME/CFS patients, that they take that time and they restore and recover. The second thing that's really important for ME/CFS patients is that they pace themselves. There's a lot of literature out there right now about the efficacy of graded exercise therapy to improve physical function in ME/CFS patients. And we had a good discussion at dinner about that today because in one sense it works. But I would never say that publicly because when you talk to most exercise physiologists, physical therapists, cardiologists, their interpretation of graded exercise therapy is that you go do some kind of, you prescribe for your client or your patient some level of exercise that quote unquote stresses their cardiovascular system and their musculoskeletal system, and they will respond by improving over time. And then you can up the ante and increase that intensity of exercise and that duration. And you do it in a very systematic fashion. And it works very well, and healthy people respond very well to this. ME/CFS patients do not. And so I don't say graded exercise therapy works for ME/CFS patients because automatically people tend to think of this as the traditional graded exercise therapy. But in a sense, if you are willing to moderate your approach with ME/CFS patients and only alter your exercise therapy in response to how they're reacting to it, in other words, if they're not exacerbating symptoms and it's helping to improve function, then maybe we can up the ante a little bit more. But the level that you start at is so much lower than patients or clients or athletes you may be accustomed to working with. It's dramatically lower, and how low is it depends on what level of function your patient has currently, what kind of symptoms they're experiencing, how well are they sleeping, do they have pain. You have to get a profile of how this individual is functioning at the present time and whether they're functioning at a pretty even keel or whether their life is like this. I feel good, so I'm going to do activity. Uh-oh, did too much, crash. Oh, okay, I'm coming out of it a week later. I'm feeling a little bit better, and here I go again, and crash. So as far as patients, we don't want that because it's those crashes, that post-exertional malaise, that is so deleterious to them. What we want is this. All right, so any exercise therapy we do with them is to improve their physical function, improve their functional activities. Can they walk up the flight of stairs? Can they carry the bag of groceries? These are the things that we're trying to get help them to be doing. So the activity level and the type will vary depending on the state of wellness or illness of an ME/CFS patient. You need to interact with them because you need to know their triggers. They need to keep track of their triggers. Some of them say, well, I know in the past if I've done this, then I feel lousy afterwards. Well, you shouldn't do that again. But the point being, they could have a variety of triggers because of the variety of systems that are involved with this illness. So physical activity could exacerbate it, too much physical activity, being on the computer, being in an environment like this where there's a lot of light, being in a noisy environment. So there are a lot of environmental triggers with many patients as well. Stress in all its various forms, environmental stress, etc., can exacerbate symptoms. So for them, I tell them, you must think cyclically, not linearly. And what I mean by that is when your day starts, you do what you need to do to get rolling, and then you rest. You lay down, you close your eyes, and you rest. So you do a task, and then you come back and rest and restore, and then you go on to the next task, and you come back and you rest and restore. So you're doing these cycles of task, rest and restore, activity, rest and restore. You're not getting up in the morning and saying, okay, I got 12 things I got to do today. Let's do one. I got to make the bed. Then I go do the dishes, breakfast and the dishes, and then I get the kids to school and da-da-da-da-da. Oh, it's 10 o'clock at night. I should go to bed. That's not how your day is going to run, and that's not how their day is going to run. It's not going to work. They will have flare after flare after flare. And so getting an ME/CFS patient to think cyclically, not linearly, in their course of their day is hugely important. Requires them to also plan ahead, because if they are not feeling so great, they want to have their house set up so that they can grab some food quickly. They're not about to cook a meal, much less do the dishes and all the Susie Homemaker stuff that, it's not going to happen. So some food that's in the cupboard that you can grab quickly, all sorts of things that they can do to plan ahead to make their life very, very basic and simple if they're not feeling well are important. The sum total, and I spent a lot more time talking about this afternoon with other strategies, is that an ME/CFS patient needs to use their energy extremely wisely because they have a small amount that they get to dole out every day. They don't have that big aerobic energy system they can tap into. It ain't working, and don't think you're going to get it working, because it's not. And I would love to say we know how to fix it. We don't know what causes this illness, and we don't know how to fix it. We know how to manage it, but we don't know how to fix it yet. We're working on it. So if you're working with clients, devising the appropriate physical activity, helping them to identify the appropriate physical activity patterns during their day is huge, cyclically. All right? Activity biofeedback, like wearing a heart rate monitor and correlating their heart rate with the activities that they're doing over time, is helpful. Because they might start to realize over the course of a few weeks, boy, every time I spend any time up at 102 beats per minute, I was really wiped at the end of the day. Maybe I shouldn't spend any time at 102 beats per minute. If they do a graded exercise test, the cardiopulmonary exercise test, they can get more specific information about that. But for right now, without giving my whole afternoon talk, I just wanted to give you a little snippet of kind of what we're dealing with ME/CFS patients and their reality of the limited amount of energy available to dole out during the day. So as far as the 2-day cardiopulmonary exercise test is concerned, what that involves is a metabolic measurement system where we measure gas exchange, oxygen consumption, carbon dioxide production. And you see here we have what's called a two-way valve in this patient, and we're measuring all the air she breathes in through here and all the air she breathes out through there. It gets analyzed, and from that we can measure her energy production and a number of other things that we look at routinely with the cardiopulmonary exercise test. can't see quite so readily that she does have EKG on, but she does. We measure blood pressure during this test, a number of other things which I'll cover in a minute. But what we can get from this test minimally is her maximum oxygen consumption or her peak oxygen consumption. It's also referred to as aerobic capacity, functional capacity. All of those are synonymous terms. And as you will soon see, we can get a pretty good objective measure of how much work she can do based on the energy she's able to produce as demonstrated in this exercise test. So here's the crux of using this cardiopulmonary exercise test with ME/CFS patients. This is a test that is highly reliable. It is a test that if I do it on a healthy person and I bring them back 24 hours later and I have them do the same test over again, I get the same results. Okay? It's a well-validated instrument or a test that as an indicator of energy expenditure, and it's used by on many patients to measure their functional capacity or aerobic capacity. And American Heart Association, College of Chest Physicians, it's used routinely. This is a highly utilized measuring device, if you will, to assess functional capacity or aerobic capacity in all sorts of patients and healthy people and athletes, etc. What we know is that if you do the repeat exercise test, you will find that, and just about anyone, heart patients, pulmonary patients, renal patients, etc., kids, old folks, healthy people as well, that they can reproduce this the second day within 6 to 7%. They'll get the same numbers on day 2. Only 24 hours later. They might be tired going in there, but we push them, we get the same numbers. We do that with ME/CFS patients, and we don't get the same numbers, interestingly enough. But you now know enough to understand why we don't get the same numbers, right? Why don't we get the same numbers? What's not working? The aerobic system. Bingo. Good. So how do we use the cardiopulmonary exercise test results to indicate ability or inability to perform physical work? Well, the term MET, how many of you are familiar with the term MET? A MET, okay. That's just another measure or another way to express oxygen consumption. So oxygen consumption, or VO2, volume of oxygen consumed, in milliliters per kilogram per minute, is expressed in METs, and in cardiac rehabilitation programs, for example, this is kind of their currency. This is what they talk about. They don't talk about mLs per kg per minute. They talk about how, what's their energy expenditure or their oxygen consumption in METs. And 1 MET is equivalent to the average resting energy expenditure of a 70-kilogram male. All right? And this is something that's been determined after testing loads of people. And so we use 1 MET as an indicator of resting metabolic rate. So when I get the data from an exercise test, I find out how many mLs per kg per minute my patient can consume to produce energy. I then convert that to METs. And now I have a way of, as you'll soon see, using that MET level information to figure out what kind of activities my patient can do. So the 2-day, you would think 1 day is torturous enough, and it is very tough for an ME/CFS patient to do this test. 2 days is not twice as tough, it's a jillion times more tough. And they do it all the time, and I'll explain that why in a minute. Not all of them do it. I obviously can't test the sickest folks because they're in bed. They can't even get to me. But what this reveals to us, the 2-day test, is how the first day of testing affects their ability to reproduce this test. Everybody else can reproduce this test, and they can't reproduce this test. So post-exertional malaise is required for diagnosis of ME/CFS. One CPET, one cardiopulmonary exercise test doesn't tell us whether they can reproduce or not. It doesn't show evidence of that. More than likely, all this one test will do is show us that they're low fit. But in most cases, in many cases, for those people who seek testing, we find that VO2 max, or their aerobic capacity based on one test, is not even subclinical. In other words, yes, you're low fit. Go do some graded exercise therapy, okay? Get into a program. Go to the wellness center. Get going. Come on. That's what it will tell us, and that's what they tell them. In reality, the values that you see from one exercise test are anywhere from 53 to 91% of what we would see in healthy controls. So not so low, pretty low, or if we were to predict their VO2 max based on a submaximum exercise test. In other words, we actually didn't take them all the way to their VO2 max during the exercise test. If we were then to predict what their maximum would be, it would be pretty low. I mean, they would still be a low percentage of the predicted values. If you do these one-day exercise tests on children who have ME/CFS, they fare a little bit better because they tend to have a little different assortment of symptoms when they acquire as children than when they acquire the illness as adults. And so we tend to see lower values in children with ME/CFS, but as they age, they lose more ground. In other words, they'll get lower and lower relative to age, sex, and activity level standards. So if I test a 35-year-old female ME/CFS patient, I always compare them to the average values for a 35-year-old female, inactive female. And in my reports, I write that comparison up as well. Does this make sense? Anybody got questions? Okay. So the strategy behind the post-exertional, the two-day cardiopulmonary exercise test is to basically elicit post-exertional malaise. That's what we do. We bring them in and we make them sicker. And the first test, we measure their functional capacity. We figure out what their VO2 max is. We know what they can do. And then we bring them back for a second test when we know they feel like crap, and we test them again. And from that information, we identify the cut points. Where in that incremental exercise test did they get, where did they begin to produce energy predominantly through their anaerobic energy system, which we know is short-lived. We can't let them live there for any length of time. They have to live down in their very low resting level aerobic system. When did that start to change during the exercise test? And that's what we figure out here. And then I take that information and I translate it into functional terms. So I'll show you examples of this shortly, and hopefully it will start to make sense. So essentially, here's what the two-day exercise test does. The first one, we figure out their functional capacity or their VO2 max, and of course, we make them sick. And we come back sicker. When we come back the next day and we test them again and we say, okay, now you've got post-exertional malaise. How much of an effect on this measurement we got here did your post-exertional malaise have? Does that make sense to everybody? Okay. So typically we get a lot of measurements when we do this. They're standard measurements if you're familiar with cardiopulmonary exercise testing. We measure oxygen consumption at maximum throughout the entire test, but we're predominantly interested in maximum values and anaerobic or ventilatory threshold. Technically, to get the anaerobic threshold, we have to measure blood lactate. And I don't do that generally with patients. And that's because patients I don't ask patients to stay on an exercise test long enough to get a good blood lactate measurement. You really need about a 4-minute, at least a 3-minute workload and at each stage to do that, and that's too long for an ME/CFS patient. Heart rate, we measure throughout the test. We measure workload, of course, throughout the test. Blood pressure we're measuring. We look at minute ventilation, how much, and you'll see in a few minutes why that is important as well. Sometimes we measure O2 saturation. Honestly, it doesn't change like you might think it would in patients. And I'm going to be doing some testing soon where I'm just going to measure peak lactate. So when they're done with their test, I'll take a little bit of blood and I'll measure blood lactate just because it's one more indicator that they worked really hard for us. And the first thing anybody who reads my reports wants to know is, did they really work? I mean, come on. Did they work? So we'll talk about that, which is why this is highlighted in yellow, the respiratory exchange ratio. Anybody know what that is? Respiratory exchange ratio? Anybody heard of it before? Okay. It is the ratio of carbon dioxide production, or VCO2, carbon dioxide production divided by oxygen consumption. And we measure this throughout the test. And what that tells us, it tells us two things. If you know anything about this, it tells you what fuels you're burning up to produce your energy. You're burning fats, you're burning carbohydrates, you're burning protein, whatever. But it also, during an exercise test, is a very good indication of how hard somebody's working. And what we want is for this value to be greater than 1.1. Greater than or equal to 1.1. When we get it up to that level, we know somebody's working hard. And for that to happen, their carbon dioxide production has to exceed their oxygen consumption. And the only way that you can do that is to be producing a lot of lactic acid and buffering it. So long story short, it's a good indicator that they're very anaerobic, working really hard for us here. So this is a very important indicator of effort during an exercise test. Because, as I said, the first thing they're going to ask is, really, did your patient really work hard? How do we know that they weren't a slacker? And so the first thing you have to do when you do these exercise tests is prove that your patient worked really hard. And if they don't work really hard, you don't have much you can hang your hat on, frankly. So you have to work them hard. And there are objective and subjective criteria for doing this. One is we look at whether or not they got close to their predicted maximum heart rate. So for individuals, generally you can say that their predicted maximum heart rate is around 220 minus their age. Did they get within 10% of that? Okay? So if you're 20 years old, your predicted maximum heart rate is going to be around 200. Did we even get you to 190? Okay, if we did, we're pretty good. There's a little problem with that. Some of the patients with ME/CFS have autonomic nervous system abnormalities, and we can't get their heart rate up very high, as you'll soon see. So sometimes that doesn't get satisfied, that criteria. Oops, that's a problem. The non-believers don't like to see that. Another criteria, did they work really hard? If they worked really hard, we should see, if I were to graph their oxygen consumption during the test, it would go up like this, right? If this is time and this is oxygen consumption, it would go up, up, up very linearly. Okay? And did I get them working so hard at the end of this test that it couldn't go up anymore and it actually flattened out like that? You see what I did with that? Does that make sense? Should have had a graph for that, sorry. But the reality is even healthy people don't satisfy this criteria very often, so I don't ever apply it to ME/CFS patients. Some of them can do it, some of them not. This one, this is a biggie. This is what we typically look for. The American Heart Association believes that this is the most important criteria, as do a lot of other people, and there's a lot of evidence to show that this is one of the most reliable criteria for showing that somebody worked really hard during your exercise test. And then, of course, there's one piece of information that we get during an exercise test called rating of perceived exertion. How many are familiar with that, rating of perceived exertion? There are a couple different scales for it. We use the 6 to 20 scale. It's called the Borg rating of perceived exertion scale. There's also another scale where it goes to 10. But essentially, this is the only piece of information you get during an exercise test from your subject or patient that tells you how they're feeling, because they're the ones that are looking at the rating of perceived exertion scale and picking out what number best describes how hard they're working. We have heart rate, and we have oxygen consumption, we have RER, we have all these physiological measures, but we don't really know how they're feeling. We know, oh, they're working pretty hard. Look, the VO2 is high, the RER is high, they're working pretty hard. But, you know, I've tested cardiac patients who were barely getting their heart rate above 110, and I looked at them, and they looked like they were about ready to just give up. And lo and behold, this one patient I tested, I said, you know, you're telling me that your rating of perceived exertion is 19 out of 20. Your face is all red, and you're sweating like crazy. I think you need to go see your doctor. And she had a triple bypass 3 weeks later. So something was wrong. When your rating of perceived exertion, what they're feeling, is very disconnected from what you're seeing here, then you know there's a problem. ME/CFS patients do pretty well with this. Okay? So generally 2 of 3 criteria indicate a max effort. There's one more criteria I didn't have up there, and that's looking at their maximum lactate values, which, again, I don't typically measure, but I'm going to start doing that, I think. All right, so how can we measure effects of post-exertional malaise on ability to do physical work? So I'm going to get my oxygen consumption measurements from my test. I'm going to convert it to METs, and then I'm going to consult my compendium of physical activities. Has anybody ever seen the compendium of physical activities? You have? Good? Great. Wonderful. You all need to visit this. Google it. Okay? All right, I'm going to show you a couple of examples of it, but I'm pretty sure, are we wireless here? Probably not. Yeah. Okay, I have a hot link to it, but I don't think we'll get to it. So I'm going to show you some examples of this. Barbara Ainsworth is the author of the compendium, and I'll tell you in a second more about that. So I'm going to do the same thing when I figure out what is this person's oxygen consumption at anaerobic threshold, and I'm going to figure out what that is in METs, divide it by 3.5, and then I have my METs. And I'm going to look at what other activities of daily living correspond to that MET level of work, too. And then I will take that information, and I will relate that, these METs, max METs, and anaerobic threshold METs, to a standard of functional impairment. The one that I use is Weber and Janicki, and it was based on, it was a standard functional impairment scale. It's based on cardiac failure patients. So my thinking is, if I use a standard of functional impairment that's applied to cardiac patients, and my ME/CFS patients have the same level of impairment, that should be compelling, don't we think so? I would think so. I thought that was a pretty good strategy. Sometimes the insurance companies don't believe that. But, okay, here are some examples out of the compendium of physical activity. So what this is, it's online. It's a collection, a compendium, of many hundreds and hundreds of studies that have looked at the energy requirements of different activities. So they've actually done the studies. They've collected the oxygen consumption values while somebody's cleaning, sweeping, doing light effort work, and they figured out, okay, how many METs is that? It's about 2.3. In the compendium, there are many of these, and they're categorized. So here you see many home activities. There are also occupational activities. There are some very strange ones. Butchering animals. There are strange ones, but whatever, they're in there. Sport activities, cycling at different intensities, and so on and so forth. Here we have inactivity light. I like this one because if you notice, light inactivity, sitting quietly watching television, is 1.3 METs, okay? You're sitting quietly right now, all right? You could be watching television, you'd be 1.3. Now, if you tapped your feet or wiggled them around a little bit, you would burn more calories. Just want you to be aware of that. Okay. So, essentially what the compendium is that it includes MET levels of various physical activities, including, and this is an important one when you're working with ME/CFS patients, occupational activities. And I'll show you some language where I have incorporated some of the MET levels for various occupational activities because, as the attorney told us earlier, you have to show in a disability case that they cannot do the job that they are supposed to be doing. All right? And so I relate my CPET values all to METs and then to activities from the compendium to show that this is about what their occupation requires, and I can show evidence of why they can't do that. Can you click on that hot link? I don't think you're wired. Yeah, okay. I didn't think so, but it was worth a try.
I can put it if you want.
That's okay. Just Google Compendium of Physical Activities. It's the 2011 Compendium of Physical Activity. I'm going to talk about what are called corrected METs, but I'm not doing this to throw you a curveball. But I think if you are going to work with ME/CFS patients, you should understand corrected METs. And when you get on the compendium website, it will explain what this notion of corrected METs are as well. But essentially, METs were devised originally for use in epidemiological studies where they studied populations of people, and they were used as an estimate of the average resting metabolic rate for a 70-kilogram male. All right? And so when somewhere along the line, and fairly recently I might add, we actually started to use these METs not for a whole population, but to apply to individuals. And that's what we're doing with these ME/CFS patients. So more recently, we have been using them for specific individuals who obviously aren't the average. You follow me? So Sarah Cozy did a study pretty recently where she looked at individuals and compared them, measured their oxygen consumption, converted it to METs, and compared them to METs from the compendium. And what she found was that the measured METs, in other words, from oxygen consumption here, actually measured values were underestimated 89% of the time. So if you took the METs from the compendium and you compared them to the actual METs that somebody was doing on an exercise test when we measured their oxygen consumption versus the estimated METs from the compendium, that 89% of the time the actual METs were underestimated. This is a problem when you're dealing with individuals, but it gets worse because the compendium METs misclassified the intensity category 12% of the time when compared to actually measuring the METs from an exercise test from VO2. But 12% of the time doesn't sound too bad, except when you looked at the percentage of time that it was misclassified when you were looking at older, low-fit women. Now, ME/CFS patients are 72% women. We would agree they're low-fit. And 30s, 40s, 50s, you see where I'm going here. So the misclassification in this particular population is much bigger than 12%. So I actually started to calculate a corrected MET when I do my reports. I don't use just the METs from the compendium, but if you go into the compendium, they will tell you in there how to calculate corrected METs. So I'll show you some examples of that too. So essentially, a corrected MET is the MET value from the compendium that has been mathematically corrected to account for the person's age, height, weight, and sex. Did I thoroughly confuse you? Are you okay with that? And you'll see why this is important in a minute. Okay, so what we've learned from doing this 2-day cardiopulmonary exercise test is we've learned that activities of daily living often exacerbate post-exertional malaise symptoms for ME/CFS patients. And that we also know, when you look at the compendium, you'll see that many activities of daily living fall into the 3 to 5 MET range. If you saw the maximum MET value or the maximum oxygen consumption of some of the people I've tested, you would understand why doing some simple activity of daily living throws them for a loop, because their maximum MET value is often lower than 5 METs. So it's very important when you're working with these patients that when you report their data, that you translate your oxygen consumption values into something that the judge, the insurance company, the lawyer can understand, and that is activities of daily living. So you've got to get it from oxygen consumption to METs, or corrected METs, to activities of daily living. This is the exercise test. This is a compendium. So you can see why I gave you a handout. There's a lot of information. This should be the top page of your handout. Metabolic anomaly on the top. This is part of a report that I write where I include the data from the exercise test. So let me just orient you to this. Here's test 1, this whole side is test 2. Here we have, this is a cycle test, by the way. Here we do 3 minutes of seated rest on the cycle, and then these are 2-minute workloads here, where we increase 25 watts per stage. So we start out with 0, unloaded cycling, and then we do 25 watts, 50 watts, 75 watts. Is there anyone in here who's done a cycle test before? Okay. Has anybody pedaled at 25 watts before? Anybody pedaled at 100 watts? Okay, so if you're healthy and you get on the bike, you probably start at 100 watts, and that's where most people with ME/CFS will finish. So you definitely don't want to start there, or you won't have a very long exercise test. Now, the exercise test gurus will tell you that for a valid aerobic exercise test, cardiopulmonary exercise test, you should ideally have people on the cycle or the treadmill, whatever you're doing. We do cycle because of balance issues, for at least 8 minutes. I'm striving for 6, okay, to 12 minutes. So in other words, you want to try to match your protocol with your patient's capabilities. And in fact, I don't do this anymore. I now do 15-watt increments. Stacy Stevens does, out on the West Coast, does a 2-day protocol, and they do it a little bit differently. But somewhere between 10 and 15-watt increments from one workload to the next, which if you're healthy, you would think it's crazy. You would be on there forever, and you would. But that's appropriate. All right? And you will VO2 max or max out your patient within 8 to 12 minutes with that kind of protocol. Anything higher than 15, 25 watts, they won't be able to stay on the cycle long enough. Just won't happen. So here's oxygen consumption, VO2, and milliliters of oxygen per kilogram of body weight per minute. Here's the respiratory exchange ratio, heart rate, systolic blood pressure, diastolic blood pressure, rating of perceived exertion. So this is what our subjects told us. And this is expired ventilation, how much air they were breathing out per minute at any given point in time. So for each stage, I have these values here. Okay? And then you go over here, got the same thing all over again. Got it? So when they, quote unquote, maxed out, this was their heart rate. As soon as we stopped the treadmill, this is the reason that we terminated the test. This was their total test time. And then this was their recovery. 1 minute into recovery, 3, 5, 7, heart rate, systolic and diastolic blood pressures during those times. That make sense? Down here, this was their anaerobic threshold. It had occurred at 16 mLs per kg per minute, right around there at the 50-watt workload. Actually, sorry, 16.1. That must have been at the 25-watt workload. It must have gone, that should be 50, I think. But in any event, 16 mLs per kg per minute is 4.6 METs. And it occurred at 63% of their VO2 max. So here's their VO2 max. 16.1 is 63% of their VO2 max. Okay? So for most individuals, healthy individuals, your anaerobic threshold occurs somewhere between 50 and 75. It could even be higher, 85, but 50 and 75% of their VO2 max. Okay, and she was at 63 in this case, which is normal if you express it as a percentage of VO2 max. But if you just look at her MET value or her oxygen consumption value, it's really low. Yeah, because her max is really low. Okay? And so this was her heart rate when she hit heart rate at AT, heart rate at anaerobic threshold. When she got to that, she was at 99 beats per minute. This is a really important number because what this tells us is when this person goes above 99 or anywhere around 99, most of their energy is derived from anaerobic metabolism. And you learned about that earlier. You know that when you're using mostly anaerobic metabolism to get anything done, you have to rest a lot. It burns out quickly, right? So if we have her doing a task where she's got to be working at 99 or 100 or even 89, I like to be more like 15 beats below this number when I recommend for people. There's a lot of anaerobic metabolism going on at this level. So that necessarily means that they have to rest a lot. Because remember, the only aerobic thing that's working for them is if they're resting. If they do any activity, they're anaerobic. Anaerobic burns out fast, and they have to rest. Got it? Is that making sense? So 99, you guys are probably at 99 when you're brushing your teeth. So that's not very high. And then I have some information about their ECG. Interestingly enough, generally we don't see remarkable ECG changes in them during exercise, for the most part. Okay, so we'll go over here to, are you seeing anything different between test 1 and test 2 here? Anything striking you? Okay, so heart rate's funny. What do we got? We got 156 here, 154 here. So heart rate's pretty typical on, is that 154? Okay, a lot higher at the beginning. Okay, so let's do this systematically. First of all, did this person max out? Did they work really hard? Now, you don't know their age, so you can't really figure age-predicted max heart rate. But I can tell you they didn't reach it, but at least they were very consistent, 154, 156. How about respiratory exchange ratio? Right there. What's the number we're looking for? 1.1 or higher. Maxed out. Maxed out. Actually, maxed out way earlier, didn't they? Way up there. Okay? So yeah, they did a good hard test for us. All right? Anything else that strikes you? Anaerobic threshold. Okay, so let's start with the max first. And we'll get to anaerobic threshold because that's pretty juicy here, right? Did they reproduce their VO2 max within 6 to 7%? I know you don't have calculators in front of you, but we got 25.5 and we got 19 something or other. It's a little blurry from my angle, but I think no. Would you say? No. Okay, good. And then heart rate did go up. Heart rate started out a lot higher here and went up, but at least it went up. All right. Blood pressure, systolic pressure should go up with each increase in workload. That did that. Over there. Yeah. Diastolic shouldn't change more than 10 millimeters of mercury. Okay, pretty stable, pretty stable. How about ventilation? Maximum ventilation, 32 liters per minute. That's probably what I'm breathing right now, frankly. I mean, you know, athletes will be over 100 liters per minute easily or more. Big people. What was that over there? 23? Okay, so this person's at 100 watts, exact same workload. On day 1, they're ventilating 32 liters per minute. On day 2, same workload, can't push nearly as much air out of their lungs, can they? Something's not right there. Okay, anaerobic threshold, 16. Oops, less than 12. Did they reproduce? Not really. Okay, good job. So we picked up that one. Okay, ventilation was a little bizarre. And you got the anaerobic threshold. These are not normal test-retest responses. Does that make sense? You all seeing that? Okay, and that also, when she hit her anaerobic threshold, now on day 2, she's hitting it at 91. So when she's got post-exertional malaise, and this was a female, then probably she just has got to lay down, because anything she's doing is going to put her in an anaerobic energy-producing capacity, which is going to make her lay down anyway, right? Good job. Okay, so here we have what I would call another metabolic anomaly. I think it's pretty obvious, this one. Almost 20 mLs per kg here, comes back day 2. Now, the insurance company could argue, geez, you didn't even get 6 minutes out of this person. What's the respiratory exchange ratio? Okay. No, what's this one? Can you see that?
8.9.
Right here?
That's 1.24.
1.24. So that's above 1.1, right? This is at 0. This is unloaded cycling. All right? Sitting at rest, just so you know, resting and respiratory exchange ratio, like right now, if I were to measure yours, you'd probably be around 0.75 or something. So she's sitting there at 93, just sitting on the bike. And then I asked her to just move her legs. There was no resistance, and she went up to 1.24. Highly, highly anaerobic. So would we agree that she did not reproduce her VO2 max? We would agree, yes. Okay, but she did max out. Would we agree with that? Some people might argue that she was just hyperventilating because she was nervous there. Well, I would expect nervous here, but I wouldn't expect nervous here, because when they start pedaling, usually what happens is blood flow increases, oxygen delivery increases, and their respiratory exchange ratio will come down a little bit, and then it'll start going back up again. So if they're hyperventilating here, so this value is really high, it will then go down and then come back up again. How about anaerobic threshold here? 10.2, 5.8. She is now hitting her anaerobic threshold at unloaded cycling. She doesn't have to do very much. And heart rate, anaerobic threshold was 109. Now it's down to 94. Okay, good. What are you seeing here? I would call this an anaerobic anomaly. Did this person max out? Yeah, look at that, 1.32. Some people don't believe that. I've had some doctors look, that can't happen. You can't do that. Yeah, it happens. 1.29, worked really hard. Same workload each time, 22, 21, whatever that is, 20, 21, okay. Pretty repeatable. I was going, oh, this person's not well, though. Geez, they repeated. And then I looked down here and I said, oh, nope, not so much. So this person repeated their VO2 max, but they did not repeat their anaerobic threshold, did they? All right. And their heart rate at anaerobic threshold went from 94 down to, what's that? 92. So it didn't change much, but their anaerobic threshold had occurred at a much lower oxygen consumption. And now this, or METs, 1.7 METs. Do you remember when I showed you the MET examples from the compendium? And I said when you're sitting there fidgeting your feet, you're at 1.8 METs. So this person is anaerobic when they're sitting there fidgeting their feet. Okay? Take a look at the respiratory exchange ratio. This is an example of what I was just telling you. Here we are at rest. This person, somebody's going to tell me, oh, they're just hyperventilating. Okay, and we go down, they start pedaling, and actually steps up blood flow, gets a little more oxygen going, but it didn't take long before, oh boy, I can't do this work anymore. The only way I can get this done is anaerobically, and so look, already they're giving us a really high effort here. Do you all see that? Okay, this is an interesting one. I will call this, here's the hint, an autonomic anomaly. Okay. Did this person max out? 1.12. What about there? What's that? 1.01. Got close, but didn't get as close as I would love to see. Okay. On the other hand, at the same workload, 100 watts, okay, they hit a heart rate of 146, and at the exact same workload on the next day, they couldn't even get to 130. So something is definitely going on with their heart rate here. So immediate post-exercise, this is as soon as they say, I can't do it anymore, we take this heart rate. And you got 157 and 127. Here's another great example. Day 1, pretty good VO2 max. This was a 38-year-old male. And that's pretty good. That's what we see in untrained college-age females. So this is a 38-year-old male. He did really well, maybe 36. Came back day 2. Did he max out?
Yeah.
On day 1? How about day 2?
Yeah.
What do you call that? Right there. Okay? He did. He hung in there, and it just got worse. It just got worse. So would you say he reproduces VO2 max? Not at all. Okay. Then look at blood pressure, systolic pressure. Systolic pressure, now notice this is 25 watt increase here too. Systolic pressure should increase 10 millimeters of mercury for every MET of work that we go up. And it's about, 1 MET is about 30 watts. So we should see, roughly a 10-fold increase in blood pressure, or a 10 millimeter increase in blood pressure here from each stage. How about here? He went 1, 2, 3, 4 exercise stages, because that's rest, and his blood pressure never changed. Now, if your blood pressure doesn't go up, how can you do work? You can't. Okay? So take a quick look at this one and tell me what you think. And then I got to zip through the rest of this. Seeing anything? Did this person max out? There we go, 125. Yeah, okay. Did they reproduce VO2 max?
Close enough.
16 to 12. If you do the math, I think maybe you'll be a little concerned. Okay, 16 to 13. And then take a look at recovery, because this is something that I always look at as well. This person had a little, now here's resting, blood pressure, 128/82. Here's 1 minute of post-exercise, all the way down to 9 minutes of post-exercise, and we're still up here at 158. We couldn't get her blood pressure, her systolic pressure down. When you come over here to day 2, we were 13 minutes of recovery. Now, most people recover within 3 to 5 minutes. okay? And we're still down here now with a diastolic hypertension, mildly diastolic hypertension, at 152/96. She's just not recovering well. Okay? I didn't put the anaerobic stuff on. It's on the next page there. So you take a look at this. 6.78 down to 4.52. 1.9 METs down to 1.3 METs sitting there. She's anaerobic, sitting at the table like you guys. Get the idea here? So her VO2 max, actually, if you did the math, dropped 17%, and her anaerobic threshold dropped 32%. This is a third or fourth person that I tested who was in or around the World Trade Center in 2001, in 9/11, which is interesting. And corrected METs, and I'll just show you a quick example. From the compendium, this was her, from test 1, this was her maximum MET value. This was her anaerobic threshold MET level from the compendium, 1.9. But when I corrected for age and gender, etc., it was down to 1.4. So this is fidgeting your feet, sitting there doing nothing, and this is just sitting there doing nothing. And then it got even worse. This woman is at her anaerobic threshold at 0.9, laying down, doing nothing, when she's experiencing post-exertional malaise. Okay, so I'm a little over time here, so let me zip through here. I mentioned this earlier. This is Weber and Janicki's scale. So if you think of the numbers that you have in front of you there and pick out any one of those patients, you should be able to categorize them either based on their VO2 max values or their VO2 at anaerobic threshold. So if you take the last woman that we tested and you look at her anaerobic threshold on day 2, the last page that we just looked at, what's her anaerobic threshold on day 2? What number have you got in mLs per kg per minute? Not in METs. 4.6. 4.6. Okay, so here's anaerobic threshold, 4.6. Would we put her there? And this is, everybody see how I did that? And you can believe that that shows up in her report too. So here's some language from her report. I might write low functional capacity and impaired ability for aerobic energy production. I think it's pretty, you would all agree with that. And unable to reproduce VO2 max within 6 to 7%. I hate to tell you this, I have to put in fatigue, post-exertional fatigue. If I put in post-exertional malaise, I get these crazy, as I said earlier today, I looked up malaise in Webster's, and it's a psychological term, and I was like, oh, you got to be kidding me. So sometimes I have to leave it out because people don't understand it. Low aerobic capacity, and I'm just going to fast forward to, you can read these, if you guys have all access to this talk, right?
Yeah.
Okay. So I'm just going to fast forward so that you can see what I write when I try to put this in functional context. Her VO2 max of 16.53 is equivalent to sweeping the floor, clearing, or washing dinner. So this woman is at max when she's making her bed. Do you see how we got there from oxygen consumption to METs, used the compendium, and we went to this? Okay? Activities that would exceed her maximum work capacity. Walking around an office. She had an office job in Wall Street. And she was fired because she was sick and she couldn't get to work. Very high stress job. But I had to equate it to the kinds of things that she did so that whomever read this understood she cannot do that. Much less, she couldn't do this. But she also had to take 5 modes of transportation to get from Long Island, where she lived, into New York City. Now, this was nothing compared to walking, taking the train, taking the subway, taking the bus, running up and down stairs to get... And so some people might say, oh, well, we can find another job she can do, but she can't get to work. You follow me? So there's more, and I'll let you look at these yourself, but... and you can, I'm happy to go through this if you want. There's one more left here if you want to try to guess it. You have it, the handout there. Actually, I should just tell you this because I don't want you to be totally flummoxed by this one. But did this person max? Maxed out. Okay, so good test. 21, anaerobic threshold 11, actually went up a little bit. So VO2 max decreased 1%. She reproduced, right? Anaerobic threshold actually went up. This person is going in for further evaluation for Lyme because we're not sure she has CFS, ME/CFS, and neither are her doctors. And based on her results here, she reproduced quite normally, even though everything was low. But it's tough when you get these because you're hoping something's wrong, but actually everything, her hemodynamics, everything is pretty normal here. All right, so the 2-day CPET protocol may provide objective evidence of impaired energy metabolism, allows you to quantify to some extent the post-exertional malaise, and reveal abnormal responses. The challenge in this protocol is in interpreting these tests, and hopefully what we've done tonight has allowed you to be able to look at these tests. You do need to know what is normal for an exercise test, what's normal for blood pressure, heart rate, et cetera, et cetera. And to know that when you do this with somebody with ME/CFS, you will make them sicker for a period of time. And I have some physicians who will prescribe follow-up IV saline. A nurse will come to their house oftentimes, or somebody will take them to a clinic where they'll have an IV saline injection or infusion over the course of about an hour for 2 to 3 days. People with ME/CFS have chronically low blood volume. So this helps to bump up their blood volume, and with many patients, not all of them, really helps to mitigate or depress some of their symptoms. So I think this is where I work, right here. Right there, that's Ithaca College. This is Cornell University. That's our big lake called Cayuga Lake. And these are our big falls. Thank you very much. Any questions? Or yes.
With chronic fatigue and fibromyalgia, I know they're very different, but they're different and they're not different. Let's put it this way. They both have central pain issues and things like this. The thing is when I look at your studies and I look at a fibromyalgia with so weak condition, what am I going to see different?
Good question. We were talking about this at dinner as well. And actually, the way the case definitions are reading, they're really starting to morph fibromyalgia and ME/CFS together. Not everybody with ME/CFS has pain. And so if you test FM only, fibromyalgia only patients, you will not see, and we were talking about this earlier, Stacy Stevens has done some fibromyalgia only patients, and about half of them will show abnormalities in the exercise test.
I think to get the abnormalities, you have to be very conditioned either way.
Not necessarily. For example, you saw the one individual who had a VO2 max of 41. Now, admittedly, he hadn't done any activity for quite some time because he was suffering from ME/CFS. But his first test was 41 or 42 mLs per kg per minute. That's pretty good. What we have to show in this test is that they respond abnormally on day 2, and he did. But most of the people that I test are low normal for their age, sex, and activity level.
I'm not going to expound on it very long. The little I know is that working with fibromyalgia, if you exercise on day 1, the next day they hurt so much, they're not going to do anything.
They may not come back for test 2, right? And so, in Stacy's data, they're showing about half of them are showing the abnormality, but they're coming back. So there's half of them who are repeating their exercise test response. And then there's about half of them who are not repeating their exercise test response. So they may not like coming back on day 2, and they may have a lot of pain, but they're still working through it to do the exercise test. There's not a lot of data on just FM-only patients with this 2-day protocol, though, and that's the problem.
No, the point I'm getting is the more I look at it, the more I kind of see it's like these 2 diseases together, 2 circles with 50% bleeding in the middle on both sides. So there's so much overlap.
There is a lot of overlap, yes. Yeah, I would agree, and that's why I think that the case definitions are starting to morph them together as well. Yes?
My English is not so good, but is there a progression when someone starts having the illness? Because I was doing personal training with someone who was telling me I have the illness, but it was milder. She could walk for, let's say, 15 minutes with me, walking on the sidewalk, and then she would do exercise normally, almost normally, but then she would ask me for, let's say, 1 week later, because she would have to rest in between. But was that the illness at the beginning, the first stage? I don't know, or...
So she was doing what she probably always used to do, or something similar to do it, right? And then she had symptoms. She had what we call a symptom flare. So that...
Not very extreme symptoms like you just showed us. She would be just tired, like a milder illness.
So what I showed you was the physiological measurements that I was taking, but I wasn't showing you the journal of symptoms they were experiencing when they came back on day 2 or even the week following. The headaches, the stomach upset, the sensitivity to light, all of the other things, the flu-like symptoms. None of that's on those pieces of paper you have. So she was having all of that, which is why you didn't see her for a week, because she was experiencing post-exertional malaise. So for somebody who's been healthy, had a normal sort of activity level in their life, to now rethink how they've got to do their activity is the big challenge. And so she came and said, oh, I feel pretty good today. Let's go do this and this and this. I used to do this all the time, and you did. And then she was the roller coaster, the push and then the crash. And that's what we need to not do, because she might feel like she's good, but she can't recover. And that's what they don't understand. Oftentimes that's what we need to... why we need to teach them about circular living and not linear living. Yes?
You tested a patient who did the test, then did a progressive workout, and do the test again to see if there's an increasement or a change with a training or...
Did you? We also talked about this at dinner. No, I have not. And I don't do exercise prescription with patients directly, but Stacy Stevens actually did do that, and it's very hard to do unless you're doing exercise prescription with them, because most people I test come in from all over the country. But in her case, she's got a lot of patients in the area, and they do follow-up exercise prescription and guidance with her. So she was able to do some case studies with them to see, and they saw an improvement. But there are not very many... There's not very much documentation on CFS, exercise program, et cetera. I mean, there are studies that have been done on that, focusing on graded exercise therapy and cognitive behavioral therapy together. And the data is equivocal. Nobody's done the 2-day protocol except for Stacy's case study. Nobody's done the 2-day and then done the exercise prescription, and then done the 2-day again. And that's what needs to be done, because as you see, the 1-day doesn't tell us very much. Even if we get their aerobic capacity up, and we do, after an exercise program, and then we test them the 2nd day, we still need to know how much they're going to crash, because they're going to crash.
anything about measuring when they are back to their first result? Like if
Or when, yes.
To rest and really being able to do the first result.
Yeah, if you think about actually doing that study, though, what you'd have to put the person through, yeah, we can't do it because we make them sick every time we exercise test them. So it would be really tough to do that. But I understand where you're going with it. That would be tough.
Yeah. Like I'm thinking about like prescription exercise. So if we can know how long does it really take to the system to recover, like it will be easier to make our schedule and plan our working and the rest and the...
Right. And so with MECFS, you can't go out and test them again because then you're going to screw up the whole system. Yeah. So what you have to do is you have to use their symptoms as your guide. And so you use their symptom profile. What's their pain level like? Did they have pain? Are they sleeping well? Et cetera, et cetera. Are they able to do their activities? And if they are, then your level of activity is pretty darn good for them. All right? And then you can bump it up a little bit. And if they say, well, we bumped it up a little bit, but I haven't been able to sleep for the last 4 nights, then you bumped it up a little too much. So you have to use their symptoms as your guide because you can't go exercise test them again, unfortunately.
Because, I know because my clients would like to know if it's possible because it's still very subjective. So I think that to have testing or somebody would maybe give his fatigue in, I don't know what to say, but... Right. Because it brings a lot of worries to the clients who don't know if they're doing it for something or just...
So one of the, it's the same thing I ask people when they when they first start exercising. Healthy people who first start exercising and they're frustrated, especially women, when the scale stops moving. The scale hasn't changed. I'm the same weight. And I go, well, how do your clothes fit? Oh, everything's loose. I had to go buy new clothes. So what are you worried about here? I look much better, but the scale hasn't changed. And I said, well, you put on a couple of pounds of muscle mass and so on and so forth. And with MECFS patients, you have to, how are you feeling? Are you able to, I can climb stairs now. So sometimes you need to use functional tests for them as their gauge. Claudine's got something to add to this too. Oh, okay. Sure. In the talk I gave this afternoon, when we were talking about graded or an exercise program over time, where we always begin with stretching, and I like to focus on core stability exercise because so often they're weak in the core, and when your core is weak, then you lose lots of energy. You expend a lot of energy moving your body around because of the weak core, just to balance yourself and do activities where, any kind of activity. So core stability and stretching are the beginning of a program that then can go to stretching and then more resistance exercise, being very careful if they have FM pain, that you're not doing heavy weights or anything because that will exacerbate that kind of pain. And then you can start to move into little modified interval training, very modified, very, very modified, and then go into maintenance because at that point you'll probably find that they can climb the stairs and they can't or take the appropriate rest but get up and down stairs or push the shopping cart or carry the groceries. But each one of those stages, so stretching core stability to stretching resistance exercise to interval training to maintenance, could be 3 months. 3 months of stretching core stability. It could be 4 months. It could be 2 months. But with a healthy person, you would never spend that amount of time, right? Okay. But with MECFS, that's how graded it needs to be, how small the increments need to be. Very slow, gradual kinds of things. Because you'll exacerbate symptoms. And if they come back, they don't show up for a week, and they say they were exhausted, then you know that you're doing too much. And your goal is to not have these things happening with them, but have them like this, even keel. Yes?
I was just curious to see, I know you said there isn't a known cause for this disease, but I was also wondering, as much as what triggers a disease, but also during the progression, exercise therapy and all that, is there anything that looks at other life habits? I'm talking about diet, I'm talking about behavior, I'm talking about sleep hygiene, just like the way a person conducts her everyday activities as well, to see what's the correlation. And I'm sure that diet also has probably an impact on your energy level, no?
The physicians, some of the most well-known physicians who treat lots of ME/CFS patients definitely approach it from a dietary perspective as well. In some cases, you'll find people who have long-standing allergies that they weren't even aware of, or you may not, or that they're deficient in their diet. But diet in and of itself is not explaining this. I mean, there's several theories about why this happens. There's, some people are convinced that it's a virus, that it's an opportunistic virus, that, people get ill and this thing just shoots in there and kind of takes over because of a weakened immune system. We don't really know, but there have been a lot of studies that have looked at sleep patterns and overall stress levels and those kinds of things. And, we haven't really found a particular profile that says you're an ME/CFS candidate. I can tell you that when I test people, I ask a lot of questions and I get history on them, and I've tested some people where I thought, geez, you should have had genetic counseling before you ever got married, or, your parents got married or something, because you have your parents' immune profiles are train wrecks and you got it all. And then I've tested people where, the parents, one of them had hypertension and that was it. And I've tested a lot of people who have been type A go-getters all their lives. Most of the people I've tested have been very active, high-functioning, own their own companies, big-time people on Wall Street. I've tested athletes, training for Ironman. So this whole notion of adrenal fatigue, have we overdone it? Have we just beat the crap out of our immune systems? It's hard to know. Some of the cytokine work that's being done is suggesting that people with CFS, we kind of didn't really understand whether they have an underactive immune system or an overactive immune system. And the suggestion with some of the data now is that it's a depressed immune system, not an overactive immune system. So we're still working on that. But we don't have a good CFS personal profile kind of thing that out there yet. It's a lot of work to be done. I'm not sure. Yep. Go right ahead. I'll be here. Be my guest.
Okay. You were saying that it's easier to manage the symptoms, that you're not fixing it yet, but you were working on it. You said that sentence earlier during your conference. So I was wondering, what is your future goals in your research, or what are you looking for the next step? In terms of fixing it.
In terms of fixing it.
We haven't fixed it yet, but we're working on it.
Well, it's not just me personally, but there are a lot of people working on it. And, one is that we have to work on getting more money because it's underfunded in the States, way underfunded in the States and in Canada too, as I understand. And it's going to take some money to fix this, but I don't think it's going to take it's not going to take a Bill Gates fortune to fix this. It's going to take a little bit of Bill Gates' half a week's salary to fix this. If somebody would like to donate that, then I think that they're, the best and the brightest could figure this out. But getting the money to do it is a big challenge right now. So there are a lot of people working on looking at immune factors and looking for that elusive virus, which we're not sure it's a single virus. We don't know, but there's the virus hunters out there, And for me personally, because I'm not looking at the root cause, I'm looking at more how can we manage it and how can we help people who have it now to be able to get disability and show objective evidence of their disease. What I would like to be able to do is characterize what happens with this 2-day exercise test well enough so that nobody can refute it, so the insurance companies can't poo-poo it, so other physicians can't poo-poo it, and they have to acknowledge that it's there, and then from there figure out how we can test, if we haven't figured out the cause by then, how we can evaluate ME/CFS patients without max testing them, because I don't enjoy doing that. It's nothing personal. I just don't like making people sicker. So I would like to find another way to do that. But for right now, this is the only thing we've got out there. When people come in and say, I've got to get disability, I have to do this. And we could say, okay, we're going to do this. And they know it. I mean, there's no mystery. They know what they're getting into. They're not going to feel well for a while afterward. Got one question here. Sorry.
I'll just add on to what she was saying before about the causes, I guess. Have you observed any link between traumatic brain injuries, such as concussions, and developing this disease, whether like long-term or short-term?
No. I haven't. I mean, I haven't. So I don't see. I'm not a physician, so I don't see patients along those lines. But I haven't seen anything in the literature about that. There's certainly cognitive effects, and we think a lot of that has to do with insufficient blood supply. They're always exacerbated during post-exertional malaise. But I can't say that. I have no idea about TBI or anything along those lines with regard to. I can tell you that of the people I've tested, I rarely get a history of concussion reported to me, if that helps. Yes. I'm sorry, I can't. So, what was your question?
How can they manage? How can you actually get better at pushing and crashing to get through regular daily activities?
Well, the simple solution to that, although it's not the simple answer to that, is not the simple solution. And the simple answer to that is to do less, to spread it out like I described this afternoon. I know you were at the talk this afternoon. Is to build your life so you live in cycles of doing a task and then recovering from the task and then doing a task and recovering. So those rest breaks where you lay down, close your eyes, build those into your day. And then also to work on improving your core stability so that when you are upright and moving around, the energy you expend is less to move around than if you're weak through the core. And also the whole spinal alignment thing we talked about, improving blood flow. But, so the short answer is to redefine your day so that you're building those recovery cycles or periods into your day. And obviously that's going to mean that your day slows down. What you accomplish in the day is going to slow down. And think about all the energy-saving tips, and I'm sure there are more out there than what I talked about this afternoon to make your life a little bit easier. Yes?
I just wondering, for those that need to go to get their disability, whether it's from insurance or is the best way for them is to have the 2-day testing? Is that the most conclusive for them to show that they have chronic fatigue syndrome? So
the question was, is the 2-day testing the best way to enter into a disability, right, to show evidence of it? It depends. So oftentimes people will come in with a neurocognitive test already done, and they may or may not have been successful with that to show that there are neurocognitive deficits. And then they'll come in for the 2-day exercise protocol, or they'll have tilt table testing to show autonomic dysfunction. And If they're working with an attorney, the attorney may say, you go get this 2-day test done, so that they have a robust arsenal of things. And I've tested some people who just want to know for themselves because they want to know for their own pacing strategy. And unfortunately, I've tested people who say, I'm doing this because I want to prove to my family that I'm ill, which tells you a lot about how some people receive this illness.